Well, hello, everyone. I am just so thrilled to be a host for this particular webinar. My name is Key Park. I'm a surgeon by training, and I work with the program in global surgery and social change at Harvard Medical Center of Policy and Advocacy. Our vision is a world where everyone has access to surgical care, including trauma care, that is safe, that is affordable, that is timely, no matter where they live. So today's webinar is really about injury care and how to manage the road traffic injuries around globally, both from a prevention standpoint and also treatment standpoint. So I'm just really thrilled that everybody could be here today. We have advocates on both sides, and we're going to try to put it all together as a comprehensive management of road traffic injuries. And to start us off, we have a special video message from President Jean Todt. He's the president of the FIA, the organizing body for all auto racing. And he is also the UN Secretary General's special envoy for road traffic safety. So we'll have a special message for him, and let's go to that video message.
Ladies and gentlemen, dear friends, I thank the AO Alliance and Foundation, Harvard University, G4 Alliance, and Cure International for organizing this timely event. Congratulations on the release of the Trauma Healer documentary, which illustrates the devastating impact of road crashes. Most critically, it highlights the immense effort we must undertake to address one of our greatest development challenges. The COVID-19 crisis has put a spotlight on the importance of building health systems for prevention, mitigation, and response. The gap in access to health services between the developed and less developed is more evident than ever. Those of us working in road safety know this reality all too well. In terms of prevention, someone in the global south may well be aware of the benefits of helmets but unable to access one because of their financial situation, or simply because a good quality helmet is not available. A comprehensive approach to road traffic injuries requires a safe systems approach, a system that places safety at its foundation. A robust trauma system to treat the injuries and road safety initiatives to prevent them are key elements. With the global community coming together during Global Road Safety Week, I'm reminded and assured you that we can collectively achieve our goals in the next decade. I thank you for your commitment.
You're on mute, Key.
Thank you. Thank you, President Todt, for that inspiring message. I want to now show you a trailer. It's a trailer from a documentary called Trauma Healers. This documentary is actually airing on over 200 TV stations in the US this month, and there are plans to go international. But this trailer really highlights the importance of the unmet trauma care in the lower middle income countries. So let's go ahead and roll the trailer, please.
Trauma is a tremendous problem in the world today. There are over 1.35 million fatalities by road traffic accidents alone each year in our world.
The global burden of injury, just how much people are suffering from getting broken, shot, burned, rolled over, fallen down, crashed into, is astounding.
Most of my patients, almost 90%, are motorbike accidents. And that's why you see the injuries so bad.
There's more road traffic accidents, there's more fractures that occur in developing world than patients die of AIDS, TB, and malaria combined.
A lot of people die by the accident, and some that came to you with a lot of bad things that it's not good to see.
Out of, I love that word, out of whack. That's such a gentle way of saying there are such dramatic disparities in the level of healthcare that people can't access depending on where they live. It's really an outrageous injustice that some people in some parts of the world can't have basic medical and surgical care.
There are countries that have 100 times fewer surgeons, obstetricians, and anesthesiologists than we have in the United States.
When you watch the news, you don't really see these people. I don't know how we can tell them that this is a reality.
The way to really successfully engage and be helpful with people who have less than you, whose culture is not your culture, is to go to where they are and in all humility say, how can I help you? And then do whatever they say. It's as simple as that.
So I will just to tell you, the producer of this documentary is on the panel today, Robert Parrish, and we'll hear from him a little bit later. But to set the stage about what we're going to talk about within this panel and provide a framing talk, I'm delighted to introduce my colleague and friend, Dr. Michelle Joseph. She's a trauma orthopedic surgeon from the UK. She's faculty member at the Harvard Program in Global Surgery and Social Change. And she will provide really the numbers behind all this and why should we care about road traffic injuries? Off to you, Michelle.
Thank you, Key. Thank you for that introduction. So good morning, good afternoon, and good evening to those of you who have been joining over the last few minutes. Welcome to our panelists. We at the Program in Global Surgery and Social Change at Harvard Medical School, G4 Alliance, and Cure International welcome you all to this webinar on the comprehensive approach to road traffic injuries from prevention to trauma. The numbers do not lie. Road traffic accidents kill. More than 1.35 million people will die on the roads each year. And this equates to a life every 24 seconds. By the end of this introductory talk, 13 innocent victims would have lost their lives. For every 1.35 million each year, an additional 20 to 50 million people will end up with injuries, and many of those will end up with lifelong chronic morbidity. The issue is significant. The age bracket that is most affected by this are those between 5 and 29 years. It is the #1 cause of death. And this loss of life predominantly occurs in specific geographical areas. Road traffic injury death rates are highest on the African continent. And when we think about low to middle income countries, the reality is 90% of these injury deaths occur in LMICs. And yet these areas have some of the most fragile trauma health systems that do not necessarily have the resources and capabilities to deal with this loss and the subsequent injuries of those who survive. In addition to there being geographical disparity, there is also disparity in gender. 3 out of 4 road deaths occur in men. And we know in the areas in which these accidents predominantly occur, men are the economical drivers. Not only is this an economical issue for the individual, for their families, it has an impact on country economics. The potential problem is catastrophic. In 2017, the World Bank Group published a really compelling report on the potential economic benefits and the social welfare gains when road traffic injuries are reduced in low and middle income countries. Taking Thailand as an example and looking at this graphic, on the y-axis you can see the dollars, which are the GDP per capita gain And on the x-axis, you can see the incremental years. A reduction of 25% of road traffic injury mortality increases the GDP potential, and that continues to increase. The economic benefits continue to increase with the 25% reductions. The optimum scenario is a 75%, but what we're looking for with the 2030 goal is for a 50% reduction in the road traffic injury deaths. To achieve all of this, to prevent the innocent loss of life, we require a comprehensive approach. A systematic approach matters. It matters because the stakes are so high. We know that the deaths and the injuries that occur from these road traffic accidents are among the most serious threats to the sustainable development of countries. Approaching these threats at a systems level is what's required. The two systems that we think of in broad terms are injury prevention and trauma care delivery. And we must think of them with the 17 Sustainable Development Goals in mind, because these are integral and indivisible targets that we know through improving prevention, improving road safety, can have an impact on other social needs, such as, for example, access to healthcare, access to better employment and education. There are a number of actors who work in the area of prevention. We'll hear about some of this today. The Decade of Action for Road Safety, the decade past, as well as the current initiative, Streets for Life. In addition, the youth voice is gaining significant traction. Global Youth Coalition for Road Safety has over 1,000 youths that are involved in various events with specific bodies such as the WHO, UN, FIA Foundation. They have members from over 400 members in 93 countries. And it's important that the youth voice is heard and advocate for the #1 cause of death in this age category. On the other side, we have trauma care and multiple stakeholders in this arena. The UN Specialized Agency, the WHO, working at a systems level approach. Innovation with Sign Fracture Care, working on the definitive orthopedic trauma care delivery in low resource settings. G4 Alliance, a strong trauma advocate. Cure International, working in multiple facilities across the world, specifically for orthopedic and neurological care delivery, alongside building capacity independence. And us at the Programme in Global Surgery and Social Change, working in policy and advocacy and trauma systems development. We will be covering both of these topics during the webinar in the hope that we will be able to impart some wisdom, some awareness, but really have these difficult discussions, because ultimately it is all of our responsibility to contribute to better care and improving injury prevention. Key and I will be moderating, Key being the Director of Policy and Advocacy, and myself interested in trauma systems development. We've heard from one of our special guests, Siwan Choi, UN Special Envoy for Road Safety. And at the end, we will hear from Siwan Choi, the member of Super Junior, really representing the youth voice. And now I'm delighted to present to you our expert panelists. We welcome Dr. Arturo Cervantes, who's a medical doctor and has a doctorate in public health from Harvard University. He is a professor and researcher at Anuak University, Mexico, and president of ANASEVI, the National Alliance for Road Safety in Mexico. He participates in the UN's Decade of Action for Road Safety in the Americas. Dr. Etienne Creux is director at the World Health Organization in Geneva, Switzerland. He chairs the International Organizing Committee for World Conferences on Injury Prevention and the United Nations Road Safety Collaboration. Dr. Ken Ozolo is a trauma surgeon and professor of surgery at the University of Jos, Nigeria. He initiated and built up the trauma system in North Central Nigeria and has decades of experience and development in trauma care delivery. Dr. Sabrina Asturias is a professor and the chief of emergency surgery at the School of Medicine of the Francisco Marroquin University in Guatemala City. She's an expert in using trauma registry data to improve injury prevention and also in training in low resource settings. And finally, Robert Parrish, an award-winning documentary film producer and director with more than 4 decades of experience. He has worked with NPR, ABC News, ESPN, NBC Sports, and American Public Television. I welcome you all. We'll now open for the panel discussion. Arturo, so my first question is to you. I would like to hear your key message as we go through all of our panelists. If you could present your key message to us now, and then we'll move on to our Q&A. Thank you.
Thank you, Michelle. Hello, everyone. It's a pleasure for Anáhuac University and the National Alliance for Road Safety to be here in this seminar organized by our alma mater, Harvard. Thank you, Dr. Key, for hosting this event. In 2007, I was invited to be part of the Ministry of Health of the National Council of Injury Prevention. And as head of this council in 2008, together with Etienne and the World Health Organization and the Pan American Health Organization, we organized the first meeting of Ministers of Health of the Americas on violence and injury prevention. This meeting was a first of its kind in the Latin American region and gave way to the United Nations General Assembly, the 58th one, where we discussed the global road safety crisis. This led to a meeting, the first global ministerial meeting in Moscow in 2009, where Mexico joined the call with other nations for the first decade of action for road safety. In Mexico, we created the first national road safety strategy called IMESEBI. And in March 2011, Mexico hosted the regional Latin American launch of the Decade of Action for Road Safety. 28 countries were present. We got the Senate of the country involved in approving the decade. The Chamber of Deputies was involved. All the governors of the country came together around the president, the Minister of Health, the Minister of Transport, and we launched the first national road safety strategy in the country, aligned with the Global Road Safety Plan of the United Nations. This plan had an aim of reducing by 50% the number of fatalities and injuries, and it contemplated 47 actions and 5 pillars. In 2012, in Mexico, a new president and a new administration, a new party took over. And in Latin America, it's very common that we have the slash and burn culture. There was no political will. There was no continuity. No resources were assigned in addition, and we needed human, technical, and financial resources. In the lack of this continuity, road safety is too important to leave it in the hands of politicians, and we created the National Alliance for Road Safety together with academia, the private sector, and civil society. I would say that in Mexico, the road safety, in terms of road safety, the first decade of action is a decade lost. Mexico flunked. There was a 0% reduction in road traffic deaths and injuries. And of the 47 actions that we contemplated in the national strategy, only 7 were done. That's less than 15%. Meanwhile, in our country, every day, 58 Mexicans die, and more than 2,000 people are hospitalized every day, and 120 will result with a permanent disability. Motorcycle and cyclist deaths have increased 400-fold, and we lose more than 1 million disability-adjusted life years every year. That's why civil society must support this sustained effort. Recently, Congress in 2020, December 2020, passed constitutional amendments and call for a general law on road safety, and mobility and road safety have been raised to a constitutional standard. I hope this second decade, we can really achieve the progress that we aimed in the first decade, and that we can work together to learn from our mistakes, which are common to many countries around the world. Mexico is not the only one that flunked in the first decade of action for road safety, and we must come together to make sure that this does not happen again. Thank you, Michelle.
Well, Arturo, that was fantastic. It's so good to hear that you have people, Mexico has people like you to champion the cause for road safety. But let's move the scope to the international stage, where WHO has a very, very important role. And we'll go to Dr. Etienne Krug to give us an idea of his experience on what's happening with road safety and what the plans are for the next decade.
Thanks, Guy. And like Arturo, it's great to be here at an event organized by Harvard, my alma mater. Actually, Arturo and I sat on the same school banks a few years ago, not so long ago. And thanks for organizing this event on the eve of the Global UN Road Safety Week, which starts on Monday and will be dedicated to tackling speed. This is why I have this sign behind me, because we're calling for a 30 kilometer per hour or a 20 miles per hour speed limit in urban centers where people mix bicycles, pedestrians, cars, etc. So thanks for having this, and thanks for bringing so many people together to talk about this super important topic. It's the leading cause of death for young people. We've heard it all over the world. And it's our fault. We created a transportation system based on cars that can go fast and that have taken the space that was initially taught for people who walk and cycle. And we have accepted now for more than a century that the price for our mobility is going to be a huge amount of people dying, getting injured, being disabled, filling our hospitals, as we've seen in the trailer, etc., etc. You know that since the car was invented, 50 million people have died on the roads. 50 million, that's more than all the deaths of World War I, or more than all the deaths of the Spanish flu, one of the deadliest epidemics we've ever seen. That's a huge price we're paying, and so I'm so glad you guys are calling for action together with us and many others. So what's tragic also about it is not only that it's such a big killer, but that we actually know what needs to happen. We need to put in place a road safety system in every country. What does that mean? On one hand, those things that we've been doing in the first decade, and I've heard from Arturo that Mexico didn't do as well as it could have. Some countries have. We've seen a decrease of 20% in Russia in the number of deaths, 30% in Brazil, 50% in the European Union. So some countries have managed in 10 years to reduce deaths. What did they do? One, good legislation and enforcement on some key risk factors like drink driving, speeding, motorcycle helmet wearing, seatbelt wearing, etc. Improvement in the infrastructure so that people can walk and cycle safely, for example. Improvement in vehicle standards and implementation. So, having electronic stability control, seatbelts, airbags, some basic things that don't cost so much and that can save lives. Better trauma care and response after the crash is the fourth point. And 5 is better data and clear responsibilities on who's in charge and who needs to do what. Because in many countries, things are falling between the cracks because it is such a multi-sectoral issue. So it's kind of everybody's in charge, which means nobody's in charge and nothing happens. So these are the lessons from the past decade. We can do it if we do this. For the new decade, we have a new layer. We want some innovation. We want to do those things that we know work, which I just mentioned, but also focus a bit more on a modal shift. What does that mean? That means stop basing our transportation system on a car-based transportation system. Think about healthier, cleaner, more active modes of transport, walking, cycling, and public transport. These need to be made safe. We can do that. Think more about young people and children. Engage more with the private sector. So these are some of the new avenues we want to, and a stronger civil society, which, as we've seen, we have a strong youth organization now, we have a strong NGO alliance, and we'll see that next week during the UN Road Safety Week, where they have organized hundreds of events literally around the world. So there's a a solid basis. We know what needs to be done, some innovation coming, and I think coming together. And that's why I'm excited about an event like this. Thanks for having me.
Thank you, Etienne. You know, I'm a big fan of WHO, and this is one of the reasons why, because they take a comprehensive approach to a world global problem like road traffic injuries. And of course, within WHO organization structure, there's trauma care, injury care, as well as emergency care. This is all part of their wheelhouse. And so we're going to turn attention now towards to Ken, who will actually tell us what does it look like to scale up trauma services in a country like Nigeria. Over to you.
Thank you very much, Ki, and thank you, everybody. I'm really super delighted to be here. It's a wonderful opportunity that I cherish so much. I work in a 600-bed capacity teaching hospital in the north central of Nigeria, and I run the trauma team. We have a dedicated trauma team, and is based out of the accident and emergency unit. Now, 10 years ago, we implemented a program of trauma registry for data collection, and we also established a dedicated trauma team. Prior to now, trauma was essentially managed by, any surgeon, and this is for the urban area. In the rural area, it's pretty much, any doctor that is on duty that manages trauma. But in our institution, we were able to establish a dedicated trauma team that's, is in charge of the initial care and subsequent care of trauma patients. Now, our health system has a lot of deficiencies, and this reflects on the quality and outcome of the trauma care that we're able to achieve. From our records, the road traffic injuries, they account for over 60%. 10 years ago when we started, it was about 80% of our trauma burden, but recently there's been an upsurge in violent, crimes and stuff, so we have a lot of penetrating injuries from gunshot wounds. But even at that, as of today, road traffic injuries account for over 60%. And the burden is such that, there's virtually no pre-hospital care because the ambulance services are very rudimentary. Okay, so most patients following a road traffic accident usually have to be conveyed to the hospital in private vehicles or by the police or other government officials. Now, even within the hospital, the services are limited also, because like I said, only few centers like ours have a dedicated trauma team that, is able to take care of the patients. But again, majority of the patients that do require admission sometimes require intensive care units, especially the head injured patients. For those with severe head injury, you would have to intubate and sometimes offer respiratory support, and trauma critical care is largely lacking, so that's invariably leads to a situation where we lose a lot of critically injured patients. And for me, what that says to me is that, that's all the more reason why a lot of attention ought to be paid to injury prevention, because that is another thing that is critically lacking. Other aspects of trauma systems are also, not very strong. Rehabilitation is near absent. Patient education on trauma is very rudimentary. There's limited research opportunities, so these are some of the problems, but despite that, we still do try to achieve what we can. Thank you.
Thank you, Dr. Kenezolo, and incredible work that you've managed to do in North Central Nigeria, and you've really demonstrated quite eloquently the impact of having the trauma registry and having a dedicated trauma team and how that differs to what happened in the preceding years before the work that you've done. Thank you for sharing that, and we'll have some more questions later. In terms of the registry that you mentioned that you've had for over a decade, I now will move over to Sabrina Asturas, Dr. Sabrina Asturas, who actually has a wealth of experience in this area. Sabrina, over to you.
Thank you, Michelle. Guatemala has one of the highest incidents of violence and road traffic accidents in Latin America, resulting in a high caseload of trauma patients. In addition, we have at least one natural disaster a year. Almost all of this resulting trauma is treated at two major hospitals. This means that two hospitals attend to the trauma needs of 14 million people. Therefore, hospitals are overcrowded, understaffed, and resources are scarce. So as surgeons working in Guatemala, we felt frustrated in terms of the type of patient care we were giving in this onset. We were tired of having to choose who lives and who dies because of the lack of resources, which is a consequence of a lack of planning and a lack of prevention policy. There was a strong need to tell our story, the actual reality of what was happening in our emergency rooms. We knew that the only way we could show this overwhelming chaos and collapse was with data. For this reason, 4 years ago, we set out to create a registry. Our first registry attempt started out with no internet, no Wi-Fi, no servers, no computers, no space for the computers nor printers if we would have them, no IT personnel, and no people to create a software. Still, we were successful 2 years later in collecting some data. But at this point, the data was not the only part of the success. The registry actually changed the culture of how data was perceived in the country. The hospital directors saw the need to install Wi-Fi in the ER. They bought computers and created a strategic planning unit where data from the ER was paired with hospital costs for the first time. It was such a success that the Minister of Health asked for the registry to be implemented in another major hospital. So in addition to the data and the cultural change, the mere existence of the registry revealed the need for healthcare workers to be trained in clinical research skills, statistical analysis, and public health policy creation. We concluded that the real power of big data does not only reside in policy creation, but the whole implementation process to acquire this big data is equally as important. The process not only started to change the culture in Guatemala, but it uncovered weaknesses in hospital infrastructure, personnel training, capacity building, and it exposed an urgent need in research training. Now, with this information, together with the big data, we can build and strengthen our system, reduce the incidence of trauma, and improve patient care. Thank you.
Wonderful. Thank you, Sabrina, for sharing all of that. It is very apparent that the starting point is crucial when it comes to development of trauma registries, and also equally the impact that they have on quality improvement and really identifying the gap. So I really commend you on the work that you have done so far and continue to do. So with that in mind, in terms of highlighting the importance, I'm going to hand over to Robert Parrish to talk to us about trauma healers and the importance of advocacy and raising awareness. Thank you, Robert.
Thanks, Michelle. I have to say that just watching all of you present your information, I had no idea that this project was going to come into focus the way it has. And I'm honored and thrilled to be here and to be providing somewhat of a platform for the thing that you obviously all care about so much. So I'm honored to be here. Thanks to Key and Michelle for embracing this project for Harvard. There are 3 other Harvard doctors other than Key who are on this documentary. I also need to thank our executive producer, Patty Fraley, who brought me into the world of Lou Zirkle and Sign Fracture Care International. And I would be also remiss if I didn't thank American Public Television and Tom Davison in particular for giving us an opportunity. When I met Lou Zirkle, that's really where everything started for me. Lou is, if you've met him, you know that he is probably one of the most caring, compassionate, amazing people that I'll just go ahead and say on earth. And after I met him and started working with him on various things, I knew that this was a story that really had to be told. And telling it took a long time, or at least putting together the story took a long time. I've known Lou for about 20 years. And we finally got everything together. And we say in television that, you know, you can work on something for a long time, but then suddenly it opens up, you know, I mean, the interest level in this particular situation just created a situation where we could in fact put something together. And I'm very happy that it's going to be on 200 stations. A lot of them are carrying it this month. We can talk more about that as we go on. But you know, when we decided to launch during the UN Road Traffic Safety Week, simply because we felt like it was a great way for that message to get out. And our goal with this project really is to bring attention to what we've called off and on during this this development, the silent epidemic of trauma. So I'm thrilled to be here, and thank you again for including me in this very impressive and esteemed panel.
Thank you, Robert. Yeah, it's been, you know, we did not know where this documentary was going to go. And for sure, looking at this event, it's just been remarkable. We're going to go now to the Q&A session. And we have so many questions from the audience. And I'm just going to take a couple out, and maybe Michelle afterwards, you can take a couple. But the one I wanted to ask the panel has to do with this question about, you know, how does the age range of these injuries affect the trauma care? So I think what they're getting at is, you know, who are we talking about? Are we talking about, you know, the elderly? Are we talking about infants? So maybe we can go first to Arturo. Thank you.
Yes, as Michelle explained, in Mexico, as in the rest of Latin America, the main causes of death in the age group from 5 to 40 years of age are trauma related. You look at children as young as 5 to 10 age group, and road traffic injuries are the #1 cause of death. And from age 10 onward, violence in Mexico, for example, is the first cause of death among young people from 10 years to 40 adults of 40 years of age. And this has been the pattern for the last 20 years, Dr. Key. So when you look at the burden of mortality, external causes of injury represent the majority of deaths for young people, but not deaths only. The amount of people injured for every death is 30-fold. So you are having a huge burden of disease in the most productive members of society, in the young adults, people who are starting their families. Remember that trauma and injury is the #1 cause of poverty and catastrophic health expenses that can drive a family to lose all their economic capabilities because of the injured person who maintains the family. So yes, it's a huge burden that is causing in our countries. And just to mention the other side of trauma, which is violent trauma, as Sabrina said, is the #1 cause of death. So #1 is guns, and ammunition, and number 2 is cars and transportation. And these, both of them are man-made epidemics.
That's a great answer, Arturo. I'm going to go to Ken and Sabrina because I want to hear stories from their own treatment experiences. What does it look like? How does it impact the family, the future, that are injured? Maybe Sabrina, we'll go to you first.
So like Arturo was saying, our emergency rooms are full of young, healthy males that actually are in these countries, the breadwinners. So the impact is far more than only his injury and only his mortality or only his disability, because it extends to all the family members. Because in Guatemala and in Latin America, it's not only the wife and kids that men support. It's usually the parents as well, the elderly, uncles, brothers, sisters. So the impact is unmeasurable in our countries. It's just unmeasurable. It's intangible. It goes. It spreads much more than just a number and just an age. It is devastating to people, to families, to entire families, the death and disability of a male in that age range. Thank you.
Thank you, Sabrina. Ken,
I think if I can jump in, I think it's important also to mention that, it's young people, but it's also those in the lowest socioeconomic classes who are most affected, those who are obliged to travel in unsafe, crowded buses. Those who can't buy a car, they're obliged to walk along the street that don't have sidewalks or bicycle lanes. Those who buy a car, but they have to buy the cheapest car without any of the safety features because they have been stripped by the car makers to make the car cheaper. So yeah, it's young people, but I think it's important to also stress how much those from lower socioeconomic status are more affected. Sorry to barge in.
Etienne, no, you exactly what I wanted to hit on, because they are the bottom of the the pyramid, but also from an access to trauma care standpoint, it's a huge impact. Ken, maybe you can comment on the affordability of trauma care services and how it impacts the poorest.
Yeah, thank you very much. I totally agree with the submission of the two earlier speakers. Trauma for us here too, what we do see is that it's a disease of predominantly young males, and these are the economically active individuals, so, and for me here, what we do see is that, just like has been highlighted, most people are in the lower socioeconomic range, and against the background of a predominantly out-of-pocket system of payments, trauma bills can send families into real crushing poverty because the person who is earning for the family is the one primarily affected most of the time, So, and then again, in these systems, you're sometimes forced into the dilemma of choosing what services can be afforded, because if you need to do a CT scan and it's too expensive for them, you have to weigh between a clinical intervention and an investigation that you would have loved to have, so that is a big challenge. But on the other side too, I think the fact that these are young adults, most of the time devoid of comorbidities, means that for me, they are able to respond to treatment if they get the right care. So for me, that's one thing that I find very encouraging, because if you do the right thing, if you have the resources to do the right thing, the outcome of treatment is actually rewarding because, they're young, healthy people. Thank you.
Thank you very much. And I'd like to follow that up, actually, Dr. Ken Azola. You talk about if you're able to deliver the care, it makes all the difference. But what if the patient actually doesn't even have that chance in the first place? I'm really alluding to pre-hospital management. A lot of the literature out there will tell you that in-hospital mortality is relatively low in some low to middle income countries because the majority of the mortality happens in the pre-hospital phase because they do not have access to care. And I know that you have worked in EMT curriculum development. I wonder whether you can speak to the importance of pre-hospital care delivery, and then maybe we'll head over to Arturo or Sabrina to jump in and speak to the importance of having that access. Dr. Cameron.
Thank you very much again. Absolutely, I agree with you because from our trauma registry, you know, our in-hospital mortality at the outset was around 7%. You know, by the time we had kept it for about 5 years, it had dropped to about 4%, you know. So, I mean, that speaks to the fact that the in-hospital mortality is actually low because a sort of natural selection has taken place in the field. If the patient can survive to the hospital, their chances of surviving the injury are pretty good. So the pre-hospital care is something that is largely lacking, you know, where I practice, you know. About 8 years ago, we did some work with the Federal Ministry of Health in Nigeria. There was an effort, because this gap was identified, there was an effort to set up pre-hospital and emergency ambulance services. Okay, but then we needed people to man the pre-hospital care, and you know there were a lot of divergent opinions. You know, I'm of the opinion that you know you could have a graduated skill such that people can be trained to provide basic support in the field enough to just get the patient to the hospital. But what was chosen at the national level at the committee was a diploma, a 3-year diploma, national diploma. You know, so we had to sit and prepare the curriculum. Like I said, this was about 8 years ago. It hasn't taken off, and this is one of my reservations because even when you do take off, you have to wait for 3 years to have the first, you know, group of graduates to speak to that. But there is no doubt there's a huge need. You know, we see people being brought in on the back of pickups, on the backs of trucks. Some are sitting in cars when they should be on a stretcher and all that. You know, and sometimes we've had the unfortunate incidents where we've had incomplete spinal cord injuries being converted to complete ones by the time the patient gets to the hospital. I mean, you get the history that the person was walking initially, but when you examine, it's not there. So it's absolutely very important. Thank you.
Absolutely, thank you.
I would add, Michelle, if I may, that the Lancet Commission on Global Surgery has advised countries, and Mexico should follow suit along with Latin American countries, of the need to create national surgical, obstetric, and anesthesia plans. Most of our countries in the Latin America region and in the developing world lack these plans. So we don't even know who has access to safe surgery, safe anesthesia, safe surgical care. And that is something very important. What we have found is that there is a lack of evidence-based public health. Our countries are not using science and are not using evidence to attack these problems. We know that the benefit of prevention is 30-fold versus the cost of reacting to the consequences. What's very sad is that we know how to prevent these epidemics, both the injury from road traffic injuries and the injury from other types of trauma, but there is very little efforts and very little continuity in applying this knowledge to really make our countries advance and move forward. And I hope that in the second decade, we can get more momentum into this movement and make this a reality.
Absolutely. Thank you for saying that. And the truth is that without these changes, we will have very little impact, and we must utilize within our sphere of influence, within our specialty expertise, but also translating some of that data, as you mentioned, the evidence to policy. And I think we'll have a last comment from Sabrina, maybe some final remarks before we close. If I could ask Sabrina maybe to just pass one comment on the translation of data to policy. And then we will have our recorded message from Siwan Choi.
So for the public health sector in Guatemala, Guatemala doesn't have like an exact process for translating data into policy because we have never had accurate data, like Dr. Cervantes was saying. The way it's done now is that budgets and policy are proposed with past data. For example, if last year the health budget was X and we survived, I think we can do the same this year, not knowing if that budget actually offers optimal care. This is what has to change. So what we did is we started collecting data, and then with this data, we had to demonstrate the value in policy making to congressmen and hospital officials. We did this through numerous meetings, letters to Congress, sending reports to the Ministry of Health. One report to the Ministry of Health is that we said that motorcycle accidents were killing more than bullets because people were not wearing helmets. And this is actually going to help to create policy. But lobbying and advocacy was not part of the initial plan. It emerged through necessity. We found that if we really wanted to reduce trauma and give that optimal care, it required us to go beyond the OR and engage those who make policy. That's the stage we are in at this moment. We're still in informing, educating, advocating part, but we do hope to establish our credibility to change the way policymakers see us and our issues. And we want to do this through data. We think that the data can help them to realize that we are a reliable source of information about the needed direction of policy change.
Thank you, Sabrina. That was a very compelling message and really a closing to our panelists. We'll now hear a video from Siwan.
Oh, can we just pause just 1 second? I want to say something before we start. Yeah. So, I want to introduce the video, if it's okay. First, so Michelle will actually do the final closing remarks. But I just wanted to say, well, thank you for everybody. But we have 63 questions. I've never seen so many people interested in this particular topic. And I think we all agree that we're going to have to do additional events to address this level of interest. And I want to introduce the video message from Siwan Choi. Most of you know he's a member of the Korean K-pop band Super Junior. He's also the ambassador, UNICEF ambassador for Asia, and Northeast Asia and Pacific. So he's kindly offered us a word, video message to encourage all of us into action. So let's go to his message. Thank you.
Hello everyone, my name is Siwan Choi, and I'm a member of Super Junior, a group that's received much love globally, and an actor, the regional ambassador for UNICEF East Asia and Pacific. As an individual taking part in pop culture, I have always had the desire to use my influence for the better, giving me the heart to participate in various activities and find interest in many different fields. It is a true honor to be able to take part in this online webinar on road traffic injuries by Harvard Medical School, the G4 Alliance, and Cure International. I found the topic of this web seminar very interesting and felt it is one that everyone around the world needs to pay closer attention to. I have seen and heard many stories from those around me regarding their experiences with road traffic injuries. I also learned of how many young people suffer from these road accidents when I was promoting the rights of children and youth through various activities. This sparked my interest in learning more about this important topic. As you have heard from today's seminar, road traffic injuries kill over 1 million people a year and leave millions more with devastating, life-changing injuries. The majority of these injuries happen in low and middle income countries, which simply do not have the medical capability and systems to treat and manage these injuries, which only leads to greater casualties. Today we heard from physicians, public health researchers, and policymakers about the toll road traffic injuries have taken and how we can work together to end this problem. I truly hope we can use the information we have learned to start deeper conversations globally on how we can work together on this issue and help those who are suffering. Thank you.
Great message hearing from our youth representative there. Thank you, Key, for also introducing him. I would like to thank every member of this panel for bringing your expertise, your passion, your guidance, your insight, and just sharing your knowledge with each of us, but also the 970 individuals who were present on this call with us today. It's been an immense turnout, and it's testimony to the importance of this discussion that we are having. We cannot not take home some of these messages. Key ones I'd like to draw out were the need for road safety systems in every country in this globe to save lives. We also need to think about the infrastructure, vehicle safety, better trauma care, what that looks like, how we work together to do that. Surgeons going beyond the OR to advocate, to develop policy, to create lasting change. All of these will impact the sustainable development goals that we seek to achieve by 2030. I hope some of those listening feel inspired by what they've heard. I hope that if there are many youth on the call, that they engage with Claim Your Space. If you go to claimyourspace.org and register to join the Youth Coalition for Road Safety, there is more to discuss, and I feel that we have not done the questions enough justice, so we will definitely be back with more on trauma. So again, thank you all for participating. Thank you all for engaging. Thank you to our panelists. It was a welcome for all of you to be here sharing with us today. Thank you all.